Let's go to Professor Martin Werner, a former VLS winner, who is here to present an extreme case. Nice
Thank
to
you,
see
Michael. Thanks.
How are you?
So I want to present a nice case of a 72-year-old male patient with a critical limb ischemia. He had bypass surgery 1 year ago, actually from a distal SFA going to the B3 segment, and he additionally had acute limb ischemia, acute and chronic actually, around 1 day. So in this image you can appreciate that the proximal SFA is patent, then you see the offspring of the bypass is occluded, and we actually have a desert calf, if you want to call it like that, with a little faint painting of the posterior tibia. So I think in many centers you would actually stop here and think about amputation or whatever, but we decided to just to see how far we can go and do a low profile undersized balloon PTA of the bypass, but as well as the BTK arteries. And as you can see here, the bypass actually was not really occluded. There was no thrombus, so we did not do any other no thrombectomy. But just the bypass was obviously collapsed because of the bad runoff at the foot. And what you can see at the end of this run, that the main vessel below the knee actually is the anterior tibial artery.
So Martin, can I ask you a question? Well, two questions. One is, what was your pre-procedural imaging? Did you know by duplex that there was a patent vessel?
Yeah, we only had duplex, so patient came in at night, so we didn't do MRA or something, but we had a duplex, and we could see that there was a proximal SFA open and the occlusion of the bypass graft.
So you didn't.
And what we thought actually was that it's a thrombotic occlusion, but obviously it was not. It was just that the bypass collapsed at some point where the runoff was too bad, and since the patient came in quite fast, there was no thrombus there, which is interesting to see. We sometimes have that you have a, let's say, a distal occlusion, and proximal of it you don't have thrombus, but just a collapsed vessel.
Well, it's a vein bypass, so this is all this functional endothelium in it. But on the duplex, the posterior tibial was open, or you didn't see any flow?
No, we didn't see any flow. So
that's remarkable to me. Right? How often would you? I mean, usually see something, right, on duplex?
You know, actually, on duplex, in this kind of cases, you see what we call sort of like a hemostasis, basically back on flow. Stasis like blood sit in if it's not thrombosed. So we see that actually in this kind of patients. But did you check for the tibials?
In the duplex?
Yes.
Yeah, well, they were checked, but obviously they seemed to be occluded at that point, or there was almost no flow. So as you can see here, the proximal part of the offspring of the anterior tibial was occluded, and we considered it to be the main artery for the runoff responsible. So that was the reason for that, was that we tried to recanalize it. From anterior, it was not possible to engage the offspring. And usually we would use a sheathless approach, of course, as you've seen in many of the cases before. But as you can see later, we needed additional devices. That's where a 4 French sheath is already in. So here is the image of the reconstitution and recanalization of the trifurcation. After plain PTA, there was a collapse of the vessel, and we were not able to treat the anterior tibial artery, and we also wanted to prevail the TPT. So that's why we decided to do a culotte stanting, a bifurcation stanting technique with drug-eluting stents. That's a science prime stents that were implanted here, and as you can see here, the runoff was good. Still, the anterior tibial artery, the main vessel, and after retrieval of the sheath, there was a very good result at the end.
Excellent.
Thank you. That was awesome. I mean, that's absolutely rescuing from the jaws of defeat, right, John?
Still going 9.
Oh yeah, that's a
So I'm not going 10. I'm still going 9.
So what's the shortcoming there?
Well, I mean, from what I could tell, I mean, you got in, the wire went down again, right? And, it's like.
But here you constructed the native.
Well, I understand. And well, he reconstructed the native down below, but that was through the bypass that Where's that SFA? That SFA bypass
No, the bypass was out,
was
right?
out, I know.
The bypass was out. In the initial image, you could see a small stump of the SFA. So,
That's
here.
Yeah.
Martin,
So
I'll give you
that's the
10.
native vessel actually.
And that's what you went through. You didn't
Yeah.
recanalize the graph.
No, we recognize the graft. You
Yeah,
can see the
recanalize
wire
the
here.
graphs, that's what I'm saying. So,
Then,
you know,
nine.
same
Oh,
as
so
the
that's
last
why
one.
John gives you a
Yeah,
nine. All right,
that's the-
okay.
You're too harsh, man. I'll give you 10 then.
Thank you.
Tony?
9.5. It's a great case.
That's a great case.
Okay,
Thank you very much.